Hi and welcome. Let's look at the surgical procedure in obstetrics known as episiotomy. So, episiotomy is a surgical incision made in the perineum, that's the area between the vagina and the anus, to enlarge the vaginal opening during the second stage of labor, which is from full cervical dilatation to delivery of the baby. It facilitates easier delivery of the baby and helps prevent uncontrolled perineal tears. The procedure is performed under local anesthesia and sutured after delivery. So, what are the aims/objectives of episiotomy? This is to enlarge the vaginal outlet and facilitate safe delivery, to prevent severe perineal tears, especially third and fourth degree. That's perineal tears involving the external and internal anal sphincters, to reduce maternal exhaustion during prolonged second stage, to expedite delivery when there is fetal distress. This is to speed up delivery in case there is a fetal distress, to protect pelvic floor muscles from irregular trauma. So, what are the indications for episiotomy? We have maternal indications and fetal indications. In the maternal indications, episiotomy is performed when there is rigid perineum, especially in primary gravidad. These are women giving birth for the first time, prolonged or obstructed second stage of labor, instrumental delivery, that's use of forceps or vacuum, previous perineal surgery to avoid disruption. So, what are the fetal indications of episiotomy? First is fetal distress requiring quick delivery, preterm delivery to protect the fragile head. So when a baby is preterm and you want to deliver such a child, you do episiotomy in order to protect the fragile bones of the head. In breech delivery to ease delivery of after coming head. So what are the types of episiotomy? First, we have mediolateral episiotomy, which is most common, especially in Africa and Europe. The cord starts from the posterior fourchette here and is directed downward and outward at 45 degrees. It could be to the right or left, so you could have right mediolateral episiotomy or left mediolateral episiotomy. So, what's the advantage? The advantage is that it avoids anal sphincter injury. So when it is done this way, injury to the anal sphincter here is avoided. So what's the disadvantage? There is more bleeding, it is more painful, and there is slower healing. Next is median or midline episiotomy. So here cut is directed straight towards the anus along the midline. So you can see the cut here directed towards the anus in the midline. The advantage here is that there is less bleeding and it is easy to repair. The disadvantage is that there is high risk of extension to the anal sphincter. So for example, if you extend the incision up to this point, there is a likelihood of the tear extending to the anal sphincter down here. Next is lateral episiotomy. So in lateral episiotomy, cut begins about 1 to 3 cm from the midline and directed laterally. So you can see the cut about 1 to 3 cm away from the midline and directed laterally. It is rarely used due to risk of injury to Bartholin's gland or duct. So you usually have the Bartholin's gland or duct around this place, so you can see that there is a likelihood of a lateral incision affecting or cutting through it here. Next is a J-shaped and anterior episiotomy. It is used rarely. Anterior type may be used in cases of female genital mutilation, so you can see the J-shaped episiotomy here. So next we'll be looking at the procedures or steps in carrying out an episiotomy. So first is preparation. Here you obtain consent from the patient and you explain what the procedure is like to the patient. You clean and drap the perineum. Draping is just the use of a sheet to create a sterile field for a surgery. And you also infiltrate with local anesthesia to reduce or prevent pain, e.g. lignocaine, 1% lignocaine to be specific. So the timing is usually during the crowning of the head. That's when the perineum is stretched and thin. So this is what you call crowning, when the baby's head is fixed in the faucet or external vaginal opening, the introitus to be specific, and uterine contractions don't push the baby back into the uterus. That's what is called crowning. So next is incision. You insert two fingers between the fetal head and perineum to protect the baby. Then you make the incision in one firm stroke in the chosen direction. So after you insert your two fingers here, in order to prevent injury or a lesion to the baby, in one firm stroke, you cut through in the direction of choice. So next is delivery. You allow the baby to be delivered gently. So this is done gently to avoid more tear due to the already made incision around that area. So next is repair. After delivery of the placenta, the wound is sutured in layers from vaginal mucosa, muscle to skin using absorbable sutures, as you can see here. So what are the complications of episiotomy? First is extension to involve anal sphincter or rectum. Next is excessive bleeding, infection and wound dehiscence, dyspareunia, that's pain during intercourse, perineal pain or hematoma, and scar tenderness. So what are the post-procedure care given? Perineal hygiene should be maintained and the area should be kept clean and dry. Give analgesics and antibiotics if indicated. Encourage pelvic floor exercises after healing. Observe for signs of infections or hematoma. So what's the follow-up and prognosis? It usually heals within 2 to 3 weeks if kept clean and dry. Follow up after 6 weeks to check wound healing and sexual comfort. Prognosis is excellent with proper care and repair technique. So we're going to be looking at patient counseling in episiotomy. So you explain the purpose of the procedure before performing it. Reassure that it will facilitate easier delivery and prevent severe tearing. Educate on wound care and hygiene after delivery. Advise on gradual resumption of sexual activity once healing is complete. Thanks for listening, and do not forget to like and subscribe for more videos.